Welcome everyone. Today we are diving into the complex and vital topic of medical therapy for renal disorders. Our journey in part 1 will take us through the physiology of the kidneys and the management of kidney stones. Let's start by looking at what our kidneys actually do. Physiology and function of the kidney. The main function of the kidney is to maintain a delicate balance of fluids, electrolyte, and organic solutes in our bodies. It does this by continuously filtering the blood, constantly altering the secretion and reabsorption of this filtered fluid. To give you an idea of the scale, the kidney receives 20% of our cardiac output, filtering about 1,600 liters of blood per day to produce 180 liters of the ultrafiltrate. Through active reabsorption and secretion, that massive volume is concentrated down to the 1.5 liters of urine the average person excretes daily. To understand how this massive filtration happens, we need to look at the microscopic level on the next slide. Nephron structure, the unit of the kidney. Nephron structure and urine formation. Each kidney houses about 1 million functioning units called nephrons, which consist of glomerulus connected to a series of tubules. The glomerulus is a spherical mass of capillaries surrounded by Bowman's capsules. It produces the ultrafiltrate purely through passive perfusion pressure generated by the heart. From there, the fluid it travels through different tubule segments, the proximal convoluted tubules, the loop of Helen, the distal, and the collecting duct. Now I will you show and discuss and in detail the shape of the nephron. As I mentioned before, each kidney houses about 1 million functions called the nephron, which consist of a glomerulus connected to a series of tubules. The glomerulus is a spherical mass of capillaries surrounded by Bowman's capsule. This is Bowman's capsule. It produces the ultrafiltrate purely through passive perfusion pressure generated by the heart. From there, the fluid it travels through different tubule segments. The proximal, the proximal convoluted tubule and the loop, also the loop of Henle, the distal tube also, and the distal tube also, and the collecting duct, and the collecting duct. Here the distal convoluted tubule. Here is the loop of Henle and the proximal Bowman's capsule. These tubules do the heavy lifting, actively reabsorbing most components and requiring a massive expenditure of energy in the form of ATP. Now that we know the anatomy, let's look at how the kidney manages water. Water homeostasis and solute excretion. The kidney has an incredible ability to regulate water. It can excrete urine as dilute as 50 millismol or as concentrated as 1200 millismol. Even at maximum concentration, the kidney need a minimum urinary volume 500 ml to eliminate the daily fixed solute load of roughly 600 millismol. If a patient produce less than 500 ml daily, a condition known as oliguria, oliguria. Then the waste inevitably builds up. These wastes are mostly nitrogenous, nitrogenous end product of the protein metabolism, primarily urea, along with uric acid and creatinine. The entire process of water excretion is tightly regulated by vasopressin, also known antidiuretic hormone. But the kidneys do much more than just make urine. Let's look at their non excretory role. The non excretory functions of the kidney. Beyond excretion, the kidney is vital for blood pressure control via renin angiotensin mechanism. A drop in blood volume prompts the release of renin, ultimately leading to sodium and fluid reabsorption. It also produces erythropoietin or EPO, the hormone erythropoietin, which tell the bone marrow to produce red blood cells, the RBCs. Furthermore, the kidney plays a massive role in bone healthy by producing the active form of vitamin D 125 dihydroxycholecalciferol, which is absolutely necessary for the gut to absorb calcium efficiently. When these functions fail, we see specific diseases emerge. Let's overview them in the next slide. Renal diseases can generally be ordered by their degree of the severity. So, this is the classification of the severity: category 1, category 2, category 3, and category 4. We start with the kidney stone or nephrolithiasis, the progress of acute kidney injury in the category 2, the chronic kidney disease in the category 3, and ultimately end stage renal disease in the category 4. It is important to note as practitioners that the objectives of our nutritional care will depend entirely on which specific abnormality we are treating. Let's dive into the first category, the kidney stone, that focus in this part of this chapter. Nephrolithiasis or kidney stone. Nephrolithiasis is highly prevalent, affecting 7% to 13% of the population in the North America. About 1 in 11 people will have a stone in their lifetime. Over half will have a recurrence within 5 to 10 years. More, the men are actually 1.5 times more likely to develop them than women. The single most important risk factor across all types of stone is low urine volume. However, there are five major modifiable risk factors that account for over half of incident stones: the body mass index, fluid intake, DASH style diet, dietary calcium intake, and consumption of sugar sweetened beverages. How exactly do these stones form? Let's check the pathophysiology. Kidney stones pathophysiology. Stone formation is a complex cascade. It requires saturation, supersaturation, nucleation, crystal growth, and eventually stone retention. Calcium stones are by far the most common, making up about 80% of all the stone, mostly calcium oxalate. Calcium oxalate, 60% to 80%. The remaining stones are uric acid, struvite, or cysteine. A major point to remember for your patients: obesity is the single strongest predictor of stone recurrence in the first time stone formers. Let's break down the specific causes of these different stone types. The remaining stone are uric acid, struvite, or cysteine, as I mentioned before. A major point to remember of your patient that obesity is the strongest predictor of stone recurrence in the first time of stone formers. Now, the causes and composition of renal stones. Looking at etiology, calcium oxalate stone are typically caused by hypercalciuria, hyperoxaluria, or hyperuricosuria. Cystine stones are the result of cystinuria, a genetic defect. Struvite stone uniquely form as a result of urinary infection, while uric acid stones are driven by hyperuricosuria or an overly acidic pH. Calcium phosphate stones are associated with alkaline urine or renal tubular acidosis. Because calcium stones are the most common, let's focus on hypercalciuria. Calcium stone and hypercalciuria. Hypercalciuria or excess calcium in the urine is the most common abnormality in stone formers, seen 30% to 60% of the patients. Here is a counterintuitive fact. Higher dietary calcium intake is actually associated with reduced risk of forming stone. This is because dietary calcium bind to oxalate in the gut, forming an insoluble complex that is excreted in the stool rather than the urine. Conversely, chronic low calcium diet can increase bone loss and fracture risk. If a patient must take calcium supplement, they should take them with meals to maximize this oxalate binding effect. The dietary acid load also plays a big role here, which bring us to next slide that I will discuss the acid and alkaline diet in urolithiasis. Excessive dietary protein, particularly from animal source high in sulfur containing amino acids, increases the dietary acid load. The chronic acidosis is dangerous. It is linked to inflammatory diseases, urolithiasis, and osteoporosis. To combat this, higher protein intake must be balanced with highly alkaline plant-based food like fruits and vegetables rich in magnesium and potassium. We can predict this effect using a model called potential renal acid load. Potential renal acid load. Now, let's look at the other half of the calcium oxalate stone, the oxalate. Oxalate stone, hyperoxaluria is found in up to 50%, about 50% of recurrent stone, or more than 50%, or exactly observed on in 10% to 50% of the recurrent stone formers. It often occurs in patients with GI malabsorption condition like gastric bypass because unabsorbed fatty acids bind up the calcium in the gut, leaving oxalate free to be absorbed into the bloodstream. Oxalate is also synthesized endogenously in the liver from amino acids like glycine and tryptophan. Interestingly, 70 or interestingly, normal intestinal flora include bacteria called Oxalobacter formigens that degrades oxalate. Patients missing this bacteria are 70% more likely to develop stone. Next, we will discuss together the uric acid stones. Uric acid is an end product of purine metabolism, with half coming from endogenous sources and half from the diet. These stones form when urine is supersaturated with undissociated uric acid, which happens when the urine pH drops below 5.5. We frequently see this in patients with type 2 diabetes and obesity. We advise these patients to moderate their intake of purine rich animal protein. Uniquely, uric acid stones are the only stone that can be dissolved medically by alkalinizing the urine to the pH from 6 to 6.5. There are few rare stones we should cover briefly, like cysteine stones, melamine, and strovite stones. Cysteine stones are rare, caused by homozygous genetic disorder, and require patients to drink more than 4 liters of fluid daily to maintain high alkaline urine. Means high alkaline urine that pH more than 7. Melamine stone gained infamy when the adulterant melamine was added to infant formula, precipitating in the distal tubules, while the strovite stone or infections stone, the other name, form rapidly in the presence of urease producing bacteria which rise the urine pH. So, how do we treat these stones nutritionally? Let's start with the fluid management. Is the first treatment. Medical nutrition therapy for kidney stone by fluid. Low urine volume is the most common abnormality in stone formers. Our goal is to maintain urinary solutes in an undersaturated state to prevent nucleation. Patients should aim for a urine volume of 2 to 2.5 liter per day. To achieve this, patients typically need to drink 250 ml of fluid at every meal, between meals, at bedtime, and even when getting up at night, with half of this intake being pure water. Beyond water, what food specific restriction should we recommend? Data restriction vary by stone type. For oxalate, patient should avoid high oxalate food like Spanish, like chocolate, like nuts. Calcium should not be restricted. Patients should aim for normal intake 1000 to 1200 milligram of calcium divided across meal. Sodium should be kept under 2300 milligram per day, as excess sodium causes the kidneys to excrete more calcium. Finally, animal protein. Animal protein Animal protein should be moderated to about 0.8 to 1 gram per kilogram per day to lower both purines and the acid load. We must also consider the role of certain vitamins and minerals. Vitamin C, patients should avoid vitamin C supplements because doses over 1 gram daily break down into oxalate and significantly increase stone risk. Conversely, omega 3 fatty acids like eicosapentaenoic acid and eicosahexaenoic acid may be helpful by decreasing arachidonic acid in cell membrane, potentially reducing calcium and oxalate excretion. Before I go to the next slide, I will discuss also the potassium and the citrate. Potassium is a protective high potassium diet full of fruits and vegetables provide alkali load that raises urinary citrate and urine pH. Citrate itself is a potent inhibitor of calcium stones because it complexes with calcium in the urine. Now, let's summarize the pathophysiology and care management algorithm of the kidney stone. The figure here you show divided into three parts. Part 1 etiology, part 2 pathophysiology, and part 3 the management. The etiology means how the stones form. The pathophysiology, what happens in the body once they form. And for the management, how we treat and prevent them. The etiology, part 1, the causes. This top section explains why kidney stones form. The diagram shows that three main background funnel down to create a specific urinary risk, which ultimately causes the stone. For the family history, genetics play a role. If your family members get kidney stones, you are at higher risk. The comorbidities, underlying medical conditions, these are health issues you might already have that make stone formation more likely. The comorbidities list metabolic syndrome, a cluster of conditions like high blood pressure and high blood sugar, renal tubules acidosis, specific structural or functional kidney issue, hyperparathyroidism, overactive parathyroid glands which control the calcium levels, malabsorption syndrome, and bariatric surgery, digestive issues, or surgeries that change how your gut absorbs nutrients, and urinary tract infections or UTI, chronic infection can alter the bladder and kidney environment. The dietary factor, what you eat and what you drink. Your diet heavily influences stone formation. Risk includes no drinking enough fluid, low fluid means too little calcium or potassium, too much oxalate found in Spanish nuts, too much of sodium, the salt, too much animal protein, meat, too much fructose, sugar, or too much vitamin C. The convergence urinary risk factor, whether it's your family history, your medical condition, or your diet, they all combine to alter the chemical makeup of your urine. This creates a perfect storm in the kidney. Low urine volume, not enough water to dilute the minerals. Hyperoxaluria, hyper, uh, hyperoxaluria, hypercalciuria. Too much calcium means too much oxalate and uric acid in the urine. Hypo, also hypocitraturia. Too little citrate means citrate actually help to prevent stones. Urine pH and elevated urine urea, an acidic or highly concentrated environment. The result is these risk factors cause the mineral to crystallize and clump together, forming the kidney stone. Now we are going to the second section, the pathophysiology. So we arrive to kidney stone formation. Now the pathophysiology, the experience. The middle section of the pathophysiology is about what happens once the stone exists. The main symptoms: the stone drops from the kidney into the urinary tract, causing flank pain, renal colic. The main symptoms: this is the classic severe pain in the lower back or side that comes in waves. The three path: once patient is in pain, there is three primary way the situation progresses. Spontaneous passage of the stone, the patient manages to pee the stone out naturally. Retrieval of the stone, a doctor has to go and remove it and lactate the stone and treat, finding exactly where the stone is stuck and deciding on a specific medical intervention. The third section of the management, treatment and prevention. This is the bottom section. Tell us what the medical team will do to help the patient right now and how to stop this from happening again. Medical management, this is the doctor job. And there is nutrition management, the dietitian and the nutritionist patient's job. For the medical management, investigate, they will identify the underlying medical cause. Do 24-hour urine collection to check those urinary risk factors we talked about and perform stone analysis, testing the stone to see what it's made of. For the intervene, they might use shockwave, lithotripsy, sound waves to crush the stone, or surgical endourologic removal using scopes to grab or laser the stone. For the medicate, they will prescribe antimicrobial therapy if there is an infection or other pharmacological treatments to manage pain or chemistry. Regarding the nutrition management, the nutritionist patient's job: hydrate, increase the fluid to make sure you produce more than 2 liters of urine a day. This is The first prevention rule: balanced diet. Normalize the excretion of solutes by avoiding high oxalate foods, lowering salt intake, and eating moderate amount of animal protein. Manage supplements. Keep dietary calcium recommended daily level and ensure vitamin C supplement do not exceed 500 milligram daily. This is the end of this part of the renal disease. See you in the next part. Goodbye.